Hello everyone, my name is Autumn and I will be presenting on anorexia and bulimia nervosa. So to start off, I'm going to get into some of the backgrounds based around DSMs 1 through 5. And for these, there was a lot of changes that went on with the DSM 1 through the DSM 5. And the DSM 1, they actually started out with only anorexia being the first like eating disorder within the DSM category and, in the DSM-1. They actually focused it as a neurotic illness and they kept it as like a food refusal instead of more of a, once we get into the criteria, more of the DSM-5's version of everything. And then moving to the DSM-2, they actually added more eating disorders, pica and rumination, but they didn't add bulimia yet. For those two disorders, it was more of a focus on like the actual illness itself rather than like food refusal. They added some focus on weight and the drive for thinness in anorexia nervosa within their criteria. For the DSM-3 and the DSM-R in the 1980s, they finally got around to adding bulimia nervosa, and they put it as a diagnosable illness within children and adolescents as well. It wasn't simply just focused around adults as it was with the rest of these past DSM sections. And they began the concept of the spectrum and like the severity and how the severity can differ with different people. It doesn't have to just be focused as it was in the DSMs 1 and DSM 2. It could now be like um a variety of severity for different people. And they actually have like a criteria for the severities, which I'll get into once we get into the like actual diagnostic criteria and such. They also brought in a little bit of the childhood trauma side of it and how that can play an influence into things such as bulimia and anorexia. And then they also started like putting in, again with that spectrum, they started putting in like an empathy sort of side to it with that the spectrum. So again, now it wasn't just focused on like this is the block criteria and you only fit into that section. Now there's a wide variety of room for people to be in. Towards the DSM-4, they finally got their own category, anorexia and bulimia, and then they also added some eating disorders that weren't specified and moved to they allowed the others to move out of like just that category. And so they had a section with criteria just for the anorexia and bulimia nervosa, and then others were listed under the other category. And then towards the DSM 5, they removed the criteria for amenorrhea under anorexia nervosa, and then for bulimia, they put in a frequency of binging episodes and they decreased some of the compensatory behaviors for that. And that's kind of where it like transitioned from the DSM-1 to the DSM-5. As far as history, I tried to find more specific in depth of where we could find it first, but as far as it gave me is the 140 years of history based around anorexia, and there is quite a bit more to it, not just 140 years. In the middle-aged area, they actually referred to this as anorexia mirabilis, and it actually put a focus on spiritual purity instead of, the now drive that we know with the DSM criteria is the drive for thinness. And it was actually explained by holiness, and it was associated with like puritanism and like perfection and morals. Towards the 1500s to the 1800s, it was called miraculous maids or nervous consumption, and it was explained with perfectionism as well as spirituality. So it was that drive to, be perfect and be the perfect person. And again, that was explained with spirituality. Don't ask me how. I don't know how they made that connection, but that was the connection that they made back then. And then finally in 1694, they got to nervous atrophy, which they explained as fasting caused by an ill and morbid state of the spirits. And it was more of a psychological thing now, getting more into the criteria for the DSM that, started everything off. And, it was added eventually to the DSM 1. But again, they used to think of it as more of like a perfectionism thing and a drive to want to be perfect and a drive to want to look perfect. Um, and that's where the history came from. So, as far as the prevalence, it stated that a large portion of the people that are faced with anorexia, they're in a group like 15 and older, and they stated that the amount of anorexia and the rate of anorexia has increased in that age group. And then as far as bulimia, it's actually decreased in that sort of age range of 15 and younger. And then they do carry a high mortality risk. There was an increase actually in the mortality risk. And then there's the peak incidence ages for bulimia that was found to be between 15 and 29 years old, and then anorexia was 10 to 14 years old. And then actually listed in the DSM, there was a 10-to-1 female ratio for both anorexia and bulimia. So for every 10 females, there was one male that was dealing with that. And then in another section that I found, it stated that there is a decline in the incidence of rates over those times for bulimia, and then again that increase for anorexia. Okay, so here's some images that I found for anorexia, and as you can see, like some of those scribbles, they're kind of looking at the differences of, what that person wants to look like and what they do look like. And then again, the photo just to help explain. So, getting into the diagnostic criteria for anorexia, the DSM lists as a restriction of energy intake and a significant weight loss and lower body weight. And again, due to the fact that, the intake of eating and nutrition is way off, so it's going to lead to that weight loss and that low body weight, as you could see in the other images. Um, there's also a bit of that, there's like a specificity for partial or full remission. So if the symptoms are kind of like wearing off and someone isn't in that full state of anorexia, they're in remission and like healing, or if they're in, like full remission, and that can be specified with the DSM, whether it's being met in a time frame. Um, Criteria B is an intense fear of gaining weight, even if someone already has like a really low body weight, having that fear of gaining weight and that like strive to not want to eat or, consume anything or take care of themselves because they have a fear of gaining that weight. No matter how low their weight may be, they still see themselves as um they may see themselves as being overweight, and so they don't want to gain that weight, or they want to maintain their, their physical being, or even, they're not happy with the way that they look, so they want to keep doing that and not consuming those calories, leading to that low weight. And then the last criteria is C, which that sort of relates around the way that they don't know how bad it is, and they're not like owning up to that. They're not like seeing how bad and how much of a risk their low weight is. So they might keep denying it, or they might keep, pushing it to the side and saying, it's not an issue, they're fine. But they don't see like the way that they look. they don't see the possible risks with them being such a low weight. And then there's a meter for the severity. The mild is a BMI of lower or equal to 17 kilograms. A moderate BMI between 16 to 16.99 kilograms. Severe would be a BMI of 15 to 15.99 kilograms. And extreme would be a BMI lower than 15 kilograms. Getting into bulimia, these images I really just wanted to use to help explain the ideation behind it. So someone might see themselves as, being really overweight when again they're not, but they also might, want to consume food, but then feel guilty for doing that. And these images kind of show the difference between that, enjoying it in the moment, but then in the future, sort of feeling that guilt and then purging that. So, they have recurrent binge eating episodes, and those consist of eating more food than someone normally would, and then, in similar instances as someone, they eat more food and then they feel a lack of control for eating that food. They have behaviors of self-induced vomiting or misusing, diet pills or laxatives in order to help them, purge of what they just ate. And then these last on an average at least once a week for 3 months, is what the DSM states the criteria to be. Um, and then B is recurrent behaviors to prevent weight gain. Again, that falls into those misuse of laxatives and the diuretic pills. And then on the schedule, again, that relates to the once a week for at least 3 months. And then the self evaluation that they might fill out or, see themselves is influenced by the shape and their weight. So, the appearance that they want to bring and the appearance that they are, and whatever information that they fill out on a self evaluation reflecting, what they are and maybe what they want to be. Um, and E, it does not occur in the episodes of anorexia. Some risk factors for these two. For anorexia, it started out with temperamental, and that was like a display of obsessional traits, and it can be like symptoms of anxiety and anxiety disorders and being obsessed over one's looks. Environmental was different cultural and settings as well as occupations. So, if you're in a culture that favors thinness, you might feel pressured to, sort of look a certain way, kind of like we do in America. And, seeing all the media that gets put out, especially like social media now, and seeing someone's pictures and wanting to, look that way or feeling bad about yourself because you see that. There's also maybe like parental factors that might pressure you into looking some way, and then as well as someone working in a field, so occupational, like modeling, um, performing, and athletes who all might be pressured into looking a certain way or having a certain body type or keeping that body type, especially athletes, and keeping up that, athletic vibe. And then, of course, genetics and physiological. So genetically passed on, onto those. So someone whose parents might have had it, they might pass on, and they might be at risk, um, and have some brain abnormality. For bulimia nervosa, it also started with temperamental, so displaying those social anxiety symptoms, some depressive symptoms, and being over anxious, and having those concerns about their weight. Environmental would be the internalization of wanting to look thinner, and especially people who have experienced childhood sexual and physical abuse, and wanting their body to look a certain way and feel a certain way because of that traumatic incidents. Genetics play a part in it, and if you are obese as a child, you are more likely to develop bulimia nervosa. And if you reach early maturation, so if you reach puberty early, you are also more at risk to develop bulimia. And then there's also familial transmission and genetic vulnerabilities. And then course modifiers, there's some severity and comorbidities that can fall into it. And so if you have a more severe disorder, it can cause bulimia to have a more long-term outcome. Some methods for diagnosis. For anorexia, I found it mostly to be based around lab testing. There wasn't much that you could do psychologically. There is a SCOFF questionnaire that I will get into in the next slide, but most of the lab testing is like hematology, bone mass, and another example that they stated was resting energy expenditure examples. And they check your chemicals in your body to see the balance of, a normal and someone who has, lower levels, and they might have, anorexia, and checking your bone mass to see how healthy your bones are based on, the nutrition that you're giving your body, and using those lab tests in order to help see like where you are on a health scale and where you might be at risk for anorexia. They did almost the same thing for bulimia, but bulimia was a little bit harder because there wasn't much lab testing that they could do or diagnostic markers that they could exactly see. But as far as like physical signs, they listed because of that purging, um, the acid that comes up with that purging can actually have a harmful harm to your teeth enamel, and it can cause your teeth enamel to look more worn down and have more of a discoloration and like chipping and stuff due to the acidity with the purging. And then they check the chemicals and the acidity within your body because of all of the purging that you do. And then again, just physical signs. And then they both deal with the SCOFF questionnaire, which actually ties into just a screening as far as someone who might be, open to those questions. You have to trust the client and develop that trust with the client to sort of get them to be more open about their feelings with this. The questions are, as follows on the screen. Do you make yourself sick because you feel uncomfortably full? Do you worry that you've lost control over how much you eat? Have you recently lost more than 1 stone in a 3-month period? And do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? And then again, on the scale, you can rate it, and that sort of gives you an idea if they are more at risk for anorexia and bulimia. And then that was taken from a whole study that did a like putting together of this questionnaire and using that to do research behind it. And then some cultural and ethical considerations, because there were a few that I thought about during this, and especially like in America with social media and stuff, just being aware of like variation in cultures and what cultures might see as, normal, or what a culture might favor, not necessarily being normal, but what a culture might favor being thin or actually having that, little extra weight, and sort of that variance in ethnicity and culture when you are, talking with your client. And then making sure that, again, with adolescents, they're still growing, getting nutrition, and really making sure that that would be, a correct diagnosis for an adolescent. Especially just considering like the thoughts and stuff that go behind adolescence and them still developing, mentally as well and cognitively, and still developing, their social course of their life as well, and what this sort of diagnosis might have on, their mental toll, and just being there for them too. Um, the DSM listed fat phobia as well, so the fear of weight gain, and maybe thinking about that on top of these diagnoses. And then the cultural side of things, um, the ethics, the APA ethics listed explaining assessment results. And again, because you're working with adolescents and maybe children, making sure that you can fully explain something to them and making sure that you can, completely get into, the diagnosis and explain it to them in a way that they understand and they don't have to be scared of, and making sure that they know that they can ask you more questions if they need clarification, especially with anorexia and bulimia. Some recommended treatments, especially when working with kids, medical and counseling integrated treatment. So making sure that they can, you know, get back up to that healthy weight, and that will involve a lot of medical treatment because obviously you can't just not eat and purge your body of all that food and then just take in a bunch of food. So making sure that they get the medical help that they need to help their body, as well as the counseling integrated portion of that, and making sure that they can talk through those emotions that they're facing when receiving those treatments. Some modalities, definitely group support, especially with children. Having a group of people that are going through the same thing and like helping them through that and making sure that they are able to support each other through that. Dialectical behavior therapy. So being able to encourage them into accepting themselves as who they are, as well as, accepting that change and the change that they're going to have to make to move away from doing that to their bodies, and that mental cognition of, taking that resemblance that they might think they look like, but actually seeing themselves as they are and understanding those risks, especially because, again, with anorexia, someone might not see the risks that their body is at when they are, doing this. Um, and then family therapy and bringing in family in order to support their child and make sure that their child might feel comfortable, or taking into consideration like any like pressure that the child may feel to make themselves look that way due to like parental pressure, and working through all of that, as well as looking for comorbidities, because especially with bulimia and the depression that someone might face, or the social anxiety of the way that they look, making sure that those can be helped as well, so that they might feel more comfortable. And these are my references. Thank you guys.